So our next presenter is Dr. Breelyn Wilky, okay, and she is an assistant professor in the Division of Hematology Oncology at the University of Miami, Sylvester Comprehensive Cancer Center, who many of you may know through John Trent, okay, and is board certified in medical oncology and internal medicine. She completed her undergraduate study at Bates College, and more importantly to me, as a fellow Rutgers alum, graduated from the University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Medical School, now part of Rutgers University, oorah, you know, go upstream, all that, and received her MD degree with distinction in research. Dr. Wilky completed her internship and residency program in internal medicine and her medical oncology fellowship at the Johns Hopkins Hospital in Baltimore, Maryland. You guys have probably heard of that one. She's a translational researcher in sarcomas, facilitating bench-to-bedside development of new therapies. After working in the lab during her fellowship, she's now focused on design and execution of clinical trials based on these laboratory discoveries and maintains a dedicated sarcoma clinic. So ladies and gentlemen, Dr.
Thank you. All right. So thank you. Okay. So I want this to be really informal. So if you guys have questions, you can write them down. If you have a burning question that comes up as we go through the slides, raise your hand, jump up and down, yell, whatever you need to do. But I do want to make sure that all of your questions get answered during this session. But to sort of start the thought process going, I put together a few slides just with the most common questions that I get asked in clinic, and hopefully some of these are questions that have come to you during your treatment or during your family's treatment. So we'll go from there. But just one disclaimer up at first, everybody's different, so it may be the same side effect, a common side effect that's affecting, I don't know, 50% of patients in a trial, but each person experiences that slightly differently. And to be fair, people's tolerance of a side effect can be different as well. So when I make guidelines or recommendations or suggestions today, remember, this is not supposed to substitute for the discussion with your doctor who has been taking care of you for years. So this may be just a new set of eyes and maybe something that you hadn't thought about before. Okay, so I thought that maybe a way to talk about the side effects to begin with would be to review what these drugs really are and how they're designed and what they're doing. So, and most of the drugs that I'm going to be referring to today are imatinib, sunitinib, regorafenib, the IBs, if you will. And these are tyrosine kinase inhibitors. What that means, imagine that every cell has this huge network of receptors on the surface that are designed to pick up signals from outside. Every cell in your body has these, but the difference is they're present in different concentrations, if you will, depending on where in the body we're looking. And the thing with the GIST cells is that GIST has a very high, you can think of it as a very high sensitivity to signals that go through the KIT receptor, right? So the drugs are designed to block not just one receptor. They're designed to fit as puzzle pieces, if you will, into many different receptors. And because GISTs are so sensitive to the blockage, the drugs work more effectively in GIST cells compared to normal cells, but side effects come because normal cells have these receptors as well. So when you're looking at the different side effects that can come from treatment, the idea is that there's a preference, or they're preferentially more toxic in the cancer cell compared to the normal cell, but non-cancer cells still have disruptions in their normal life cycle and function, which is where most of the side effects come from. Okay, so when we're talking about this family of drugs, there are some common patterns and some common cells that are normal that get hit with the treatments. But some of the drugs tend to have more of an effect on what's called the VEGF, or the vascular growth factor receptor. And those can give you a slightly different constellation of side effects, such as hypertension, kidney issues. And sunitinib and regorafenib tend to have more VEGF target effects. And so I'm going to cover those side effects, but a lot of what I'm referring to is more of what we see with imatinib. Again, as we talked about, these can vary from patient to patient, and they change. The constellation of symptoms that you have changes over time. People oftentimes start out with one particular pattern of side effects, and we work together to come up with a plan for that. And then the next visit, that's gone away, but then there's a new problem. And so We really have to, for each of my patients, I try to see where they're at, see what's bothering them now, and be willing to change and be flexible depending on how things are going at that particular time. A couple of things I wanted to mention. Again, most of you, I'm sure, know this, especially those of you who have been taking these drugs for a very long time. But remember that imatinib and most other drugs are designed to be taken with food and water. If you take Gleevec on an empty stomach, it does not dissolve. It does not get absorbed to the same amount that it's supposed to be, and so you're effectively under-treating yourself. On the other side, if you take Gleevec with some of these listed medications here, or supplements even, there's a pointer, oh it is, you can actually over-metabolize your Gleevec pill, and that leads to a much higher level than what we normally expect. That can cause side effects that you wouldn't normally have. A story that I always tell is my patient who thought she was being good by going to a party and not drinking alcohol, but she had Fresca instead, which is full of grapefruit juice, and she had horrible diarrhea for several days as a result of that. So you want to look at grapefruit juice is a common fruity flavor in a lot of things, so you want to keep an eye out for grapefruit and some of its derivatives. Okay, so these are the major side effects I'm going to briefly touch on. Swelling and fluid retention, nausea, vomiting, abdominal discomfort, loss of appetite, fatigue, the muscle, bone, and joint aches and pains, diarrhea, various types of rashes and other skin issues. Briefly, I'll talk about blood count abnormalities and chemistry abnormalities that you might come across, and increased blood pressure is one of the other common ones. The serious ones that I want to just point out that you should call right away if you were to experience sudden shortness of breath, especially if it's at rest, and especially if it's associated with swelling in the legs, chest pain, yellowing of the skin or eyes outside of, so sunitinib can sometimes cause a little bit of baseline yellowing. This would be a sudden change in the amount of yellowing in the white part of your eyes. Severe headache, foamy urine. These are some of the big red flags that we would definitely want to know about right away. What's funny? Foamy urine. Okay, no, it's true, but that's what it looks like actually. So especially for the VEGF drugs, if you are to have an acute change in your kidney function, one of the first signs of what's called proteinuria, or loss of protein in the urine, is foam. And so it almost looks like you're peeing beer. Yep, like a beer. We're talking about when you pee, it looks very foamy compared to what you might normally expect. It's a sign of protein in the urine. Yeah. Right here. Yep. And you guys can get a copy of these slides. There's nothing proprietary at all, so we can make sure that you have access to those. So iron supplements are a little complicated. Yeah. So the idea with iron is you don't want to take it at the same time that you're taking the Gleevec. Okay? So it can interfere with absorption. This is actually true for a lot of medicines with iron. So if you've decided to take iron by mouth, you want to space it away from other pills and medications that you're taking. I think the usual guideline is about 3 to 4 hours. So say if you're taking your Gleevec at night, you could try to take your iron pills maybe 2 hours after lunch or something, so you're at least 4 hours away if you can. Yep. I got a bunch of people here. Go ahead. So I don't typically make Tylenol absolutely not permitted for my patients. The idea is if you're taking Tylenol round the clock, that's going to be stressful on the liver. We worry about the liver with many of these medications, so it's important at least to discuss it with your doctor. You know. I have not seen kidney stones with Gleevec, at least not that we could definitively associate with Gleevec and not something else. Pardon me? Nephrolithiasis. Lithiasis. Mm-hmm. Right, nephrolithiasis. Oh, you had a stone in your kidney they were watching? Okay. Not to do anything. Yep. We'll go right. Pradaxa, so double check with your doctors. Pradaxa, I don't believe interacts, and I have patients that are on Xarelto, and that is actually okay. Xarelto is rivaroxaban is the other name for it, but Coumadin for sure is a big no-no. Lovenox shots are usually okay, but double check with your doctor. Oops. Pardon me? Yes, pills to control the blood pressure. So again, all of the medicines you want to run through a database or have your doctor look and double check and make sure there's no interaction. I'll tell you most of the time, if it comes back as mild interaction, use caution. It's not going to change what I do, but I'm going to watch more carefully for side effects and expect that patients might have a little bit more trouble than they normally would if they weren't taking Gleevec and the blood pressure medicine at the same time. But it's rare for me to have to drop somebody's blood pressure dose down because they're taking Gleevec at the same time. It's just that in theory, you've been very patient. Go ahead. Pomegranates are probably one of those fruits with theoretical similar concerns. If you go, I was trying to find a better list of all the prohibited fruits. I mean, there's probably a dozen things like candied oranges, very random things. So I'll try to get you a better list, but I would not be surprised if pomegranates are considered grapefruit-like. So we'll find out. Kiwi? I don't know. I think kiwi's okay. Kiwi's okay. Go ahead. I don't think so. I mean, it would have to be a full supplement to cause a problem. The trace, if it's a trace iron supplement, not a full strength iron supplement, it should be okay. Again, with anything, you probably want to avoid taking it together with Gleevec, but we got people in the back. Go ahead.
They give you this paper and you write up all the medicines you take. And because I have other issues going on in my life, the thing that frustrates me is that you write it all down, then they come and ask you and again, and then they'll go and prescribe something that you can't take. And I have had to spend money on stuff that I can't use, yet I have told the doctor in advance that, okay, I'm on this medication, and I try to always make sure that all my meds definitely don't interfere with the Gleevec. All the rest of the stuff I can deal with. But that's a problem for me, and I want to know if other people have that problem and what can we do about it, because it's frustrating for me.
Thank you.
I found that sometimes when I've filled prescriptions or ready to fill them, I've gotten phone calls from the specialty pharmacy telling me I shouldn't really be using that medication. And that's happened once or twice in my case. So the best thing is to do, if you have a specialty pharmacy, I think, is call them first before you fill a prescription, so you're not wasting your money, and then call the doctor and say, listen, I know you recommended this for me, but it's going to interfere with what I'm taking with the Gleevec. They can check online, too, if it interacts. I know my doctors check before they even prescribe something now.
I have an app on my phone. There's an app called Hippocrates, or you can go on drugs.com, and there's a way you can add the medicines, and it'll spit out whether or not there's an interaction. And it's up to the doctor to determine whether it's a significant interaction that will change prescribing that medication or not. But it's not that difficult. And my patients are really good at reminding me to check. So, wait, can I take this with Gleevec or not? So usually that prompts us to do it, but it's frustrating. Any other questions right now? Okay. Okay, so fluid retention and swelling, otherwise known as edema. In most of the big clinical trials, that was reported in up to 75% of patients on imatinib. Really 1 to 2% were severe, meaning that they had to be admitted to the hospital or it caused severe problems. It's usually mild, and the most common places wind up being in the lower extremities, in your legs, below your knees. But eye puffiness, as you can see in this patient here, is also a problem. It might not be in just one place. You may have weight gain, bloating, feeling more short of breath, and these are where we get into more of the severe side effect from swelling and fluid retention. So what we try to do is we try to be conservative and support it as best we can. We rely on you for daily weights and to let us know. I have some patients that actually will measure their legs to know how big their swelling is. Basic management for swelling holds true, like limiting salt intake, although that's often hard, especially if you're having nausea. And as you'll see coming forward, or in a couple slides, we're going to talk about the importance of salt and water hydration. So we have to balance. But limiting salt, elevating the legs if you can. We try not to use diuretics or water pills unless we absolutely have to. And if we do it for a very short period of time because those will lead to electrolyte abnormalities. And what I tell patients is that the Gleevec makes you get edema and swelling because it makes the blood vessels leaky. Okay, when you block the vascular growth factor, it pokes holes in the veins, it seems like. And so some of that protein and fluid will leak out of the blood vessels where it belongs and into the soft tissues of the leg. So a diuretic works by clearing out the fluid inside the vessels, which is not the problem. The problem is that it's out already. So usually diuretics have very limited effectiveness. Does that make sense? We also recommend massage therapy, support stockings, treating it almost like a lymphedema type of picture. And then just one more thing to mention, again, the red flag is if you have swelling in one leg only or much greater in one leg compared to the other one, what would that make you think of? Anybody know? Very good. All right. And what about if you have swelling in your legs, you've got a little bit more shortness of breath, some chest discomfort? Exactly. And what medicine? Okay, now we're getting it. Now I'm really going to quiz you guys. You're expert patients here. So what medicine? Which medicine gives you more of a risk for heart problems? Would it be imatinib, sunitinib, or regorafenib? Very good. You see, you are expert patients. I don't know why I'm here. So yeah, sunitinib, up to 10 to 15% of patients have been reported to have congestive heart failure. And I have a patient, it was striking. She was on sunitinib for months and literally one day woke up and could not breathe. And she wound up going to the hospital. They did an ultrasound of her heart and it was squeezing at 20% as opposed to a normal 55 to 60%. So, and it came out of nowhere. The good news is that with medical therapy and stopping the medicine, she returned to a completely normal ejection fraction or squeezing of the heart. And we were actually able to put her on regorafenib, which is what she's on now, and she didn't have any problem with that. So sunitinib is definitely the problem child when it comes to that. Mm-hmm. Yeah, so she got regorafenib. She's on Stivarga. Yeah, so we had the discussion. You're absolutely right. Many doctors were, oh, you shouldn't have any GIST treatment after that. We can't give you a tyrosine kinase inhibitor. And we didn't feel comfortable with that because obviously, she has pretty advanced disease. So, but she was able to tolerate Stivarga without a problem. Yes. General guidelines and have to be taken into consideration for your own case. So the idea is you're more likely to get a clot if it's a sudden change. So if you're used to walking around normally and you get on a plane and fly to Europe, that's the most common scenario where people get a clot because they're suddenly sitting with their leg down for a long period of time. We know that in cancer, including GIST, the body naturally has stickier blood, for lack of a better way to put it, and clots can happen more commonly. And if no one's ever looked to rule out that your swelling has to do with a clot, it's reasonable to look. But I wouldn't expect that to be a common thing.
You say that because I had several surgeries, 6 to be honest, in 9 months. And 3 of the 6, my leg blistered profusely from ankle to here. And even when my leg was cut off, my stump blistered. And we had gone through, we couldn't figure out. And when I came to the meeting in 2010, somebody vaguely mentioned it because I wanted to know what was happening. The doctors couldn't figure out. And somebody said that they had vaguely had that. But after looking back at it, I realized that the time that I come off my Gleevec before surgery makes a world of difference. And my doctor, the orthopedist, was telling me that it's okay to be off your cancer medicine about 3 or 4 weeks, but he never would consult with my oncologist, and my oncologist is, this is absolutely ridiculous. So I went through all of that blistering, not knowing what had caused it, and I really think it is the Gleevec. So do you have any other results on
Yeah.
that? No, the time, like when I've been having these surgeries, they always make me come off the Gleevec for a while, and I would come off a few days. One had me a week, another one 2 weeks, and I noticed that all of them were different, but the ones that were closer to it, my leg would blister really bad. I mean, they would turn into wounds. And I didn't know until someone said to me that they thought they had experienced something similar, but no doctor has really told me that. So that's what I was hoping to find out if there was any literature on that.
About the
because I
blister.
have that problem.
So if you're really swollen, it can lead to for sure. So we'll sit down and no, it's okay afterwards. That's all right. It's a good question. Okay. All right. So the next most common one, the nausea, vomiting, abdominal pain constellation. So this is also another one that's notorious for evolving over time. I've had several patients that were fine for the first couple weeks that thought that the Gleevec was going to be a vitamin and they weren't going to have any problem, but it sort of catches up with you over time. And then I've had people that were sick as could be when they first started taking it, and then it got better. So the strategies I like to try, I use a lot of antiemetics, so Zofran or Compazine or Phenergan, whichever one helps you. And I tell people to take it about half an hour before they're going to take their Gleevec. So a typical strategy for my patients would be maybe 5 o'clock at night, take your antiemetic. 5:30, you're going to take your Gleevec with your meal, and then that way you have the antiemetic in your system before you're going to try to eat and have your medication. And I tell people to take it with their biggest meal of the day, and I like doing it at nighttime because theoretically, if you're sleeping through the highest levels of the Gleevec, maybe you won't. If they're having problems with nausea, maybe you'll sleep through some of that nausea. But I have patients that like taking it in the middle of the day as well. Again, you want to make sure there's no interacting medications, foods, or supplements. If you're having a lot of trouble with nausea, small, frequent meals and snacks. Avoid the foods that seem to trigger your symptoms. I have some people that will use a straw for beverages or for really strong smelling foods and medications, or if not medications, foods and drinks. And you also want to make sure that you don't have any liver problems on your labs, which is the other thing that we check for. So the red flags here, again, anything that's suggesting that you could be having something more serious going on in your stomach. Sudden onset of new nausea or abdominal pain. Obviously, any bleeding or black stools, that would be concerning for potentially an ulcer, or maybe if your tumor is in the stomach or you have tumors in the stomach, it could have irritated them to the point where they're bleeding. Right upper quadrant pain or jaundice would point towards a liver problem. And then the red flag and the cutoff for when you need to call your doctor for regular nausea is if you can't take fluids or pills. Those are the two things that you're going to have to come in. The oral medicines are not quite doing it, and you may need fluids and IV antiemetics. That's what I tell people. Fatigue. This one is also very common and probably the hardest one to treat, in my opinion. So people describe it as running out of steam at the end of the day. They describe it as just an overwhelming feeling of weakness, feeling exhausted with minimal exertion compared to what they used to be able to do. And the first thing you want to do is rule out anything else going on, especially if it's worse than it had been the last visit, if you will. So other common causes that make fatigue worse: anemia, which we've talked about with several people here today. Poor nutrition or the wrong kinds of nutrition, although that's, again, very patient to patient specific. Uncontrolled pain, that's a big one. If you're in pain and you're just sort of toughing it out and living with it, that exhausts you over time as well. Difficulty sleeping, very common. Depression as well. So, and I mean, you may not even feel depressed or down, but just the imbalance of the chemicals, just enough to set you off a little bit, can cause fatigue as well, and can often be helped by medicines for depression. Thyroid. So sunitinib is the most common medicine that can mess with your thyroid, but we've seen it with the other medications as well. So if you're having persistent fatigue, you may want to check your thyroid hormone as well. Interactions from other medicines again. So we tell people to try to prioritize your activities for the best times. Make sure that if you're, we do want you to exercise and push yourself a little bit, and the best time to do that is when you're feeling your best. You want to try to stick to a balanced diet. I got a question a little bit earlier about the sugar diet for cancer in general, and my general consensus, without going on too long, is that balance is really the key. And if my priority for my patients is that you're eating something and you're not losing weight, and we're not getting low albumin levels or protein levels in the body. So if you're cutting out all of your carbs and all your simple sugars, your body switches to digesting protein for nutrition, and if you're losing protein, that's going to be a big problem. So I like balance myself personally. Lots of water, that's the answer to everything. Drink more water, hydrate more. Sleep, exercise, as we talked about. Certainly strategies to combat stress or depression are often helpful. Meditation, yoga, medication, or counseling if needed. And then our psychiatrist at Miami is fantastic, and she actually does use medications with a little bit of a stimulant to them, like Ritalin or related newer agents, to give people a little bit of pep, particularly if there's also depression underlying the situation, and they can really help with concentration and some quality of life. But that's a discussion, again, on a patient-by-patient basis. Aches and pains. About 30% of patients, they can also be severe, very tough to sort out. And this one's a tough one to figure out exactly what's going on and what the best way to manage it is. You want to make sure you don't have an increased muscle enzyme level, something called creatine kinase. So we check that on the labs. Relatively rare, but it has been seen in studies. It could be in non-specific areas. It can migrate. It can be associated with doing something in particular. It can be associated with doing nothing. The management that I recommend, again, hydration, answer to everything, electrolyte and salt. So here's where we hope that you have this problem and not the swelling problem, because our recommendations for this problem may make your swelling worse. So electrolytes and salt oftentimes can help people. Apparently, pickle and olive juice, tonic water with quinine, not a gin and tonic, as Dr. Trent loves to say, but tonic water is good. Calcium and magnesium supplements, I mean, that's a little bit extreme, but if your numbers are low, we may recommend this as well. And I just heard about the ivory soap at the foot of the bed thing fairly recently. Whoever has gotten this to work, you got to fill me in on how that one works, but that's entertaining. You want to try to avoid the Aleve and the Tylenol. So Tylenol is the liver, as we just mentioned. The Aleve is hard on the kidneys and can give you a risk of worsening stomach upset, reflux, ulcers, irritation of the stomach, and kidney problems. So we try to avoid those, but once in a while it's okay. Once in a while, if that helps your pain, and I use it in my patients as long as their numbers look okay. For certain areas that seem to be a problem, lidoderm patches can help a little bit. Hot packs, cold packs, massage, again, supportive, conservative things we try to get away with. Diarrhea. So this is another one that comes and goes. Again, you want to keep a food diary, or at least write down some of the things that really give you problems. Check for the activating foods that we already mentioned. And this one also is managed by small, frequent meals, bland foods. Try to avoid the spicy stuff, the fatty foods that seem to be triggers for most people. I recommend that yogurt is fine for most of my patients. There's a lot of questions about the immune compromise and whether having probiotics is a problem. Most people, their white count does not get low enough into neutropenic range where I feel like that's an issue. And most of my patients feel that yogurt and probiotics really do help keep things a little bit more regular. lots of water, fiber, and then if persistent, we do sometimes use antidiarrheal medications to help people tolerate this. Loss of appetite, so kind of goes along with nausea, and I recommend to people, because I will say, have you tried Zofran? And people come back and say, but I'm not nauseous. But sometimes your brain is not smart enough to figure out the difference between nausea and just not feeling hungry. And so because they're relatively free of side effects for most of the anti-nausea medications, I always recommend that we try that and to see if that makes it a little bit better. If it's not that those don't really help you, a lot of it is psychological. So you need to convince yourself that what you're going to eat, that it's time to eat, and that even though your hunger mechanism is not there for you, make it as appealing as you can. Pretty, bright colors, something that looks and smells good to you if you can. And then it becomes almost a discipline. It's like losing weight where you're counting calories, but it's the other way around. You got to make sure that you're getting a set number of calories in with a balanced diet, and while making it as appealing as possible. A lot of my patients decide they're never going to eat any dairy or any bad sugars and go vegetarian on top of everything else. And this is when you have a new diagnosis and you're trying to get your body used to this new medication, a chemotherapy. I tell people it's not the time to try to have these major dietary changes, but protein is important, and so we tell people to try to get a high percentage of protein in if you can. Wow, time flies. Oh goodness, I didn't think this would take that long. I'll go faster. So rashes and skin conditions. So there are a ton of different ways that rashes pop up, and they're one of the more common side effects as well. Now, most of my patients have redness or itching or dry skin or hives. I had one lady that got the most terrible hives every time with Gleevec. But then with regorafenib, there's also the risk of something called hand-foot syndrome. And so that's what this is. This is actually a picture of hand-foot syndrome. And it really is a cracking, blistering phenomenon of the hands and the soles of the feet that is really quite miserable. Tough to treat. With all rashes, we try to manage them as we would a rash coming from anything else. So if it's itchy, we're going to recommend antihistamines. If it's open, like acne, we may use a topical antibiotic or sometimes a systemic antibiotic like doxycycline or something like that, like you would treat really bad acne. Topicals, creams, moisturizers for dry skin as best we can. We try, for mild rashes, we try not to drop the dose or interrupt your treatment, but there are some people, especially with Stivarga, that I've had to take a drug holiday and then restart at a lower dose, and that's thought to be very reasonable. Keep an eye out for the sun. You can get sunburned a lot easier on these medications than you would imagine. I have one lady who swore that she started growing hair on her face, although I've not actually, I couldn't find it when I was looking at her, but she swore that her hair was changing. So some of those symptoms also can come with the TKIs. Pazopanib and sunitinib actually can give you white hair. Pazopanib is not a standard treatment for GIST, but there's a phase 2 study that was reported in Europe this year that suggested that pazopanib may have some activity prolonging survival over basic supportive care. So I think we're going to see more and more of pazopanib in the future. Mm-hmm. Thinning hair is tough. Thinning hair. Nutrition, I tell people make sure, again, we're trying to rule out any other contributors. So nutrition, zinc, lots of zinc in your multivitamins. Make sure your thyroid is completely normal because low thyroid also can give you thinning, brittle hair. But we're kind of stuck. That's a hard one. I have some of my patients swear if they do chemo, like they came back after chemo and their hair got all thick and grew in really heavy, and so they're like, you got to tell your patients that are losing their hair that chemo is the way to go, and that's the magic solution. But not in this setting, but. Okay, and the last couple slides. So blood issues, what are we really drawing all the blood for? What are we really looking at? So white count, red count, platelets. White cells fight infection. It's rare right away to run into problems with your immune system, meaning low numbers of white cells with Gleevec or related medications. But over time especially, those numbers will start to creep down. common to see a low lymphocyte count, which is a special type of the white blood cells, and that can make you more susceptible to viral infections or sometimes fungal infections. But severe infections, like with other types of chemotherapy, are relatively rare. Anemia, low red count. So I've talked with a couple people. The low red count makes you tired, energy problems. You want to make sure you're not bleeding somewhere, and then you want to rule out other contributing things that are fixable. So anemia can be caused by, again, thyroid, iron deficiency, a low iron. It can be caused by low B12 or folate. So those are easy tests to send. You can make sure that all of those, what I tell people is that you need the building blocks to make your blood. You need the machinery, which is in the bone marrow, to process all the raw materials, and then it has to get spit out into the circulation. So chemo, Gleevec, all of these medicines, they mess up the machinery. Most people don't have problems with the building blocks. So that's why when people ask me, if I eat a bunch of liver, is my blood count going to come up? And fortunately, usually not, but because the machinery is the problem. We do sometimes use medicines to help the machinery kick it along, like Aranesp or Procrit, these I guess I'm thinking of the hematopoietic thing. Basically, it's a growth factor for the red cells specifically. So we'll sometimes do that, but you have to make sure that everything else is in line before. So rapid heartbeat, feeling like your heart is racing with activity, shortness of breath, those are all signs of anemia. Platelet count, so if your platelets get too low, you have the risk of bleeding, so we watch that. Blood clots, you're not going to pick that up on labs that often, but we keep an eye out for it anyway. Bleeding from the GI tract. And let's see, what else? Yeah. And then as far as the liver tests and things like that, I mean, I'm not going to get into that as much because, again, you want to try to check for anything specifically that's making the liver problem worse. Kidney function, pretty rare for imatinib. There's only that's not the most common thing that we see, but we do still keep an eye on it. It can be a sign of underlying toxicity from the pressure and things like that. So, yes, I'm getting waved. Mm-hmm. Mm-hmm. Yep. Good to know. Mm-hmm. Right. So most of the time with chemo or in short-term treatments, we try to stay away from EPO, which is or erythropoietin, the fancy name for the Procrit, Aranesp growth factors. The reason is theoretically you're stimulating the stem cells in the bone marrow, and there's some risk that people think of developing a leukemia or a cancer of the blood cells from red blood cell specific growth factors. Now, the other problem too is that people were abusing them. They were prescribing them when you didn't really necessarily need to, and then people were getting very high levels. There's also people say, oh, you're anemic, let's just give you a growth factor instead of sorting out why. So if people are iron deficient, a growth factor is going to do nothing for you. So you have to rule those things out. So there's a very complex system to try to regulate the use of them, but it originally stemmed from the concern for leukemia. And most of the time for chemo, it's a temporary problem. And if the body just has enough time, it's going to come back up. So using it in the middle of cytotoxic chemotherapy like we do for other cancers, you're better off giving somebody a transfusion and bumping them up to get them through the low period. Imatinib's different because you're going to be on this continuously, or some of these other medications. Does that help? Okay, so for now I'll just open it up to questions until you want to go. Mm-hmm.
Long-term side effects.
Long-term side effects. Yeah, so, I mean, imatinib has not been around that long, and so I think you guys, those of you who have been on this for years and years, you are the people that are telling us what those long-term side effects are. So as you mentioned, the kidney question and the worsening anemias and lower blood counts are certainly coming to attention more so than they were before. I think many of the side effects you have early get more and more cumulative. To my knowledge, there's not been any people don't know of any increased risk of other cancers or long-term risk of heart failure or things like that that we typically expect to see with other medications that we've been on for a long time. So it's actually quite well tolerated in the long term. Broken bones, to my knowledge, there's not an increase in osteoporosis or risk of that. I don't know if others have had trouble with a vascular necrosis or anything. Yes, ma'am. Chemo brain. More out of it and trouble concentrating. So what we typically do for chemo brain or trouble concentrating is some of the things we talked about. So there's if you go online or you work with a therapist, there are actually what they call brain games or cognitive behavioral therapy. So it's basically exercise for your brain. And so these range from games to things like word recall and Scrabble and almost like intelligence types of tests. And the idea is to keep your brain stimulated and make you concentrate on something even for a brief period of time. So that's cognitive things with chemotherapy in general, and I would definitely recommend trying that with Gleevec as well, because I suspect it's a similar phenomenon. You also want to make sure that these other issues like sleep, you want to make sure that people are sleeping. You want to make sure that any undiagnosed depression is treated as well, because all of those things make the process worse. So and then exercise and things like that as well also help with concentration that we've seen. Yep. Hydration is always the answer. Drink more water. No problem. Other questions? Okay. Thank you. Oh.
You mentioned all these side effects are, they could be experienced by patients, but we also know under Sutent and Stivarga we have side effects that are not experienced, like hypertension and thyroid functions and these. Maybe you comment a little bit on this.
So those side effects that you mentioned, the hypertension, the foamy urine, real worse kidney dysfunction than sort of the chronic increase in creatinine and things like that. These come from the VEGF factors. Sunitinib, notorious for low thyroid. So these problems and hypertension as well, we can usually control them with medicines for that particular problem, just like if you had it and you weren't on those drugs. The problem just comes, we have to make sure it's something that interacts okay with whatever medication you're taking. The sunitinib is probably the biggest problem child, I think. In my clinic, I have more problems trying to deal with those types of side effects with sunitinib. But usually with aggressive treatment, we're able to get on top of the blood pressure issues. If it comes down to a significant kidney problem or proteinuria, then we have to have the discussion about the risk and benefit from it. Maybe take a dose holiday, drop the dose down a bit, restart it after the body's had some time to heal. Pazopanib is the same way. As we start using Votrient, is the other name is for it, Votrient. As we start using that more and more, we're going to have similar issues because it's a very vascular drug as well. Yeah.
I was just wondering about skeletal problems, if you're taking Gleevec or something like that. Is there anything that you can think of that does something to your head or your skeleton?
So is it pain or, okay.
But there was something about muscular, skeletal, somewhere in the notes. I gotta look at it.
Mm-hmm.
Did you know anything like that?
So we want to make sure that your calcium levels are okay. Sometimes people do drop their calcium on Gleevec, and so long-term deprivation of calcium would certainly not be a good risk for osteoporosis or other bone problems. Frankly, I haven't seen that many skeletal events in patients, but I'm happy to look into that in more detail and see. More commonly, it's musculoskeletal pain and irritation, and it's hard to sort that out. As to what that is. But no, I will let you know. So I'll stick around if anybody wants to delay heading on the bus. But have a wonderful night, and thanks so much for.
Thank you very much.